Welcome, everybody, to Wildcard Wednesday. It is April 8th, 2026. I'm Stacy Buck, President and Senior Consultant of RadRx. So I'm happy to be back this week with two cases. So the first one we're going to look at is a lower extremity case that's relatively straightforward. And the second one that we're going to look at is a very complex thrombectomy case. I actually had to look at it off and on and kind of reason my way through it and try to figure out how I would code it. And I was like going back and forth. So it took me a little longer to feature that particular submission, but there's a lot to discuss in that report concerning documentation and, needing, possibly some additional detail. So let's go ahead and jump into our cases for this week. So our first case involves an angioplasty of the anterior tibial artery. So this particular case, you are seeing exactly what was submitted to me. I do not have any information about any prior imaging that occurred on this patient. The information in the clinical history matches the reason for the exam, and that is the atherosclerosis with rest pain in that leg there with critical limb ischemia. So that's all that we know. So based on this information, we cannot determine whether or not we're going to code diagnostic angiography. What I would do is I would go back and look into other parts of the medical record and see if I could make that determination by looking at documentation from the physician, whether it's in a consultation note, whether it's in a progress note, and then see if I can make that determination. I will tell you going into this report, there is nothing in the body of the report that indicates that the decision to intervene was based on the imaging that occurred. So I would not assign the diagnostic angiography codes for this case. However, I have noted them in the case just again for teaching purposes, which is typically what I do. So as always, I start with the procedure list, if there's one at the top of the report, just to get a feel for what I'm looking at. So we see that we have access at the left common femoral artery, an abdominal aortogram, bilateral extremity angiography is performed. We see revascularization attempt of an occluded right ATA with angioplasty. And then we see that that's all that was performed. And then there was the closure. So when we look into the report, I'm going to jump down to the meat of the report here where the physician actually gains access. So the report notes pre-procedure ultrasound demonstrated a patent left common femoral artery. And then we see the lidocaine used for local anesthesia under ultrasound guidance. A left common femoral arteriotomy was made, image documenting needle position archived. So here we have our 76937 for that ultrasound guided vascular access. We do have our required documentation components. Then from that left common femoral artery access, the catheter gets advanced into the abdominal aorta, and here the physician performs angiography of the abdominal aorta. Now notice the findings that are given. It says the abdominal aorta is normal in caliber and smooth in contour, and it also mentions the native bilateral renal arteries. Now, if you've listened to past episodes of Wildcard Wednesday, you know that I've talked about the components that should be documented to assign 75625 or 75630. A complete abdominal aortogram should ideally contain findings for the abdominal aorta, the origins of the renal arteries, and also the origin of the celiac, the SMA, and the IMA. So that leaves no doubt that there was a complete abdominal aortogram. But this particular report only mentions the abdominal aorta and the renal arteries. So when I'm performing audits, generally what I do with these is if they've coded them as a 75625, I do not mark it an error. I don't mark it as an error, but I do put in a recommendation for documentation improvement and then give a reminder of all of the components that should be noted in the particular reports. I think sometimes the physicians, they're probably seeing, the origins of these vessels, but if they're normal, they're probably not commenting on them. But because we see that the renal arteries, there was a notation there, we know that the catheter was high enough up in the aorta to actually perform an abdominal aortogram. So the 75625 would be the code here because the catheter then gets withdrawn down to the aortic bifurcation, and then a selective bilateral lower extremity angiogram was performed. It says selective, but the catheter is in the aorta, so technically that's not a selective catheterization. And then there's findings for both extremities there. So we had the catheter that was placed, high in the abdominal aorta for the first contrast injection for the abdominal aortogram. Then it's pulled down to the aortic bifurcation for a second injection of contrast. And so then that ends up being 75716 if we were assigning the imaging codes. Again, based on the limited documentation I have, I would not be assigning the imaging codes. You'll also notice that I have the catheterization code 36200 crossed out because as we get further in the case, we actually move into selective catheterization, but then ultimately we end up with the catheterization being bundled because there is a lower extremity intervention. So let's look down at the second page of this procedure, and you'll see that I have highlighted the pertinent findings that we're going to look at to determine, do we have a straightforward lesion or do we have a complex lesion? So we see that the ATA has a chronic occlusion, and the next paragraph says that the physician elected to attempt ATA revascularization and mentions I was able to traverse a few centimeters of the occluded ATA. However, at this point, I had great difficulty making any additional progress. Angioplasty balloon was actually deployed across the occluded ATA. So an angioplasty was performed. So we do actually have a portion of the vessel where angioplasty was able to be performed. And it says, following this, I did have additional targetability and attempted advancing the system further, was unable to advance the system more than 1 centimeter. And then it was clear that antegrade revascularization was not going to be successful. So for this particular situation, we do have angioplasty that was completed, even though the entire vessel angioplasty was not completed in the entirety of it, but there is a portion, and it is for the complex lesion. So that ends up being coded with 37282 for that complex angioplasty for that. Where's my little sheet? I wanted to double check that code. When I do them from memory, I always want to double check them. But I don't see my sheet on my desk. But I believe it is the 37282 for the complex ATA lesion there. Okay, so now I'm going to jump down to the second case, and this is the one that I had to read through it multiple times, and I had to dissect it and figure out exactly what work was being done, through which accesses the work was being done. And depending upon how you're reading this report, you can end up with two different sets of codes. So when we look at the beginning of this case, we have at the top, it says pulmonary thrombectomy, right heart cath, and peripheral angiography. So those are the three main procedures that we are looking at here. So when we go and we jump into the details of the procedure, we see that we have access at a right common femoral vein. Then from there, the catheter goes into the right atrium, the right ventricle. It says pressures were obtained. The catheter was not able to be advanced to the pulmonary artery. That wedge catheter was not, and then it went into the right ventricle. And then we see a pigtail catheter was then advanced over the J wire and then used to manipulate up into the pulmonary artery, and pulmonary artery pressures were obtained. So looking at this first paragraph of the report, we see that pressures are noted in this particular paragraph. But when I look at the rest of the report, there's no further findings in the report to determine if this was truly a full right heart catheterization. When we go down to the actual end of the report, I'm going to skip ahead for just a moment. You're going to see in the conclusion, the only thing mentioned in the conclusion here is your PA pressure, the heart rate, and then the O2 stats, and that's it. So in the body of the report, I don't see anything else about a right heart cath. So what would I do in this situation? Well, if I have access to the rest of the medical record, I'm going to go look over at, the flow sheet potentially, from the cath lab, and I'm going to see if there's additional information there. If I need to, I will actually go and query the physician to determine, was this actually a full diagnostic right heart cath or was it not? This is going to be key to assigning the correct codes for this case, because if we do report the heart cath code, the 93451, then that is going to require us to then use the angiography codes, the pulmonary angiography codes that go along with the heart cath codes, and not the regular angiography codes for pulmonary angiography. So this one point here does affect coding of the entire case. So what I've tried to do in this case is give you both possibilities as I'm going through the case, based on the notes that I made, and then based on, further research and getting additional answers, how those codes may look. So that was the first question that I had with this report. Do we truly have a full RHC? Because if we only have pressures, then it's not necessarily going to be the full right heart cath, and so we wouldn't code for that. But why it's significant is because catheterizations get bundled with the heart cath codes. Also, when we get into those imaging codes that go along with cardiac cath, catheterization is bundled into those. So like I said, it does affect the coding. So let's go on to the next paragraph where it says pulmonary angiogram is performed. Now, at this point, where the catheter is in the pulmonary artery, then we have a 36013 if it's in the main pulmonary artery. It doesn't say that it's been advanced into, the right or the left at this point. That would be a 36013. The catheter is going to eventually get moved like further, but at this point, you see that I have also the 93568. So if this was a true heart cath, a 93451, we would be assigning the 93568 for this work, and then we would not even be considering the 36013 because the catheter work is going to be bundled with the 93568, and that is for non-selective pulmonary angiography when it's performed in conjunction with a heart catheterization procedure. Then you see when we go down to that second sentence, it mentions that the catheter was advanced over the J wire to the distal left pulmonary artery branch system. Then we go down further, and then it says next, the 20 French Inari aspiration catheter was then advanced over the Amplatz wire to the left pulmonary artery branch system. Now here, we don't know if it went into, it says, the left PA branch system. Okay, but I feel, do I have enough detail here to know that it went beyond the left pulmonary branch itself? Maybe someone could possibly make the argument that they want this to be a code 36015, that it's a branch beyond the left pulmonary artery. But with the language in the report, I'm not 100% convinced because it says distal left PA branch system. I'm like, so it's kind of like iffy in this. So I went more conservative and I put a 36014 for the catheter placement. Now, again, if we had a right heart cath, it's not going to matter because we're not going to assign the catheterization code. And then here we see that a left pulmonary, the left pulmonary angiogram is going to be performed. Okay. So here actually, no, that's where the code should have changed. I didn't know. Okay, I'm changing it further. All right. The codes are changing. I did put it down further. Gotcha. For that. So, okay. So then we see if we had the right heart cath, we wouldn't have the 36014. So at this point, depending upon right heart cath or not, it's 75741 potentially for the imaging that occurred. If we're not coding the right heart cath, if we are coding the right heart cath, then we're going to be still looking at our the heart cath codes, the pulmonary angiography codes that go with heart cath. Now, okay, we see now aspiration catheters directed to the location of the thrombus and multiple aspirations are performed. So we do have the thrombectomy being performed in the left pulmonary there. So that's going to be a 37184. When we come down to the next paragraph, then we see that the catheter is now moved into the distal right branch. So we actually see the same work being done on the right side there. And so again, when we're looking at our imaging codes, now we have bilateral imaging that occurred. So again, depending upon whether or not it was truly a right heart cath, if it wasn't a right heart cath and we're just going with the pulmonary thrombectomy, we're going to have a 75743 for our selective imaging. At this point, that means our non-selective code above would go away. But if we do code the heart cath, then we would assign 93573 for the bilateral selective imaging that occurred. And interestingly, the 93568 still stays intact, and you can code the non-selective and the selective when we're talking about a heart cath being performed. So I think it's a bit of an odd rule where for the peripheral, you can't code the non-selective imaging with the selective, but with the heart cath, you can code the non-selective imaging also with the selective imaging. So then from there, so again, now let's go back to, okay, if we were reporting our catheterization codes, then what are we going to report? So conservatively, I chose 36014 for this based on the documentation. You could say that it's a 36015 for the catheter placement potentially. Again, if we're assigning the heart cath code, we wouldn't assign this because it would be bundled. And we also have our thrombectomy over on the right side, which is a 37184. So essentially what we end up getting for the thrombectomy is 37184, and you would use modifier 50. So that's for this particular, the bilateral thrombectomy that has occurred at this point. And this has all been through the same access. When we come down to the next paragraph, it says that there's a left common femoral vein access that was obtained with ultrasound guidance. We don't have the required documentation to code ultrasound guidance again, so we're not going to do that. And then here, through the left common femoral vein access, it says that through the micropuncture sheath, the glide wire was then advanced to the proximal right atrium level. Over this wire from the left femoral access, the Inari flow retriever XL disc was deployed in the inferior vena cava, just below the level of the right atrium. And so here what we see is what's happening in this paragraph. It says that at this time, the 20 French aspiration catheter was pulled back further, so the tip of it was at the same level of the 24 French sheath. And so what's happening in this part of the procedure is that it appears as though when the thrombectomy was being performed of the pulmonary, now we have this issue where we have a portion of the thrombus that has now has moved, okay? So you'll see where it says both the catheter and the sheath were flushed, removing large amount of thrombus. This is from the IVC. And then it says venogram through the 24 French sheath revealed ongoing obstructive thrombus in the distal inferior vena cava and ostial right common iliac vein, as well as ostial proximal left common iliac vein. And then we're going to another axis, a separate axis. So let's talk about this one paragraph and what's occurring. So here from this paragraph, we know that this is a separate axis. So we're going to code this like its own procedure. So the axis is through the left common femoral vein. Catheter goes into the IVC, which is a 36010. Now you'll notice that I have the 37187 there with question mark, question mark, question mark. The reason being is because the problem that we're having in the IVC here and in the iliac veins is a result of performing the thrombectomy from the pulmonary arteries. So, because if you see, I kind of skipped over it here in this paragraph here, the last sentence, it says venogram performed through the 24 French sheath, revealing large thrombus burden stuck to the tip of the 20 French aspiration catheter. So what's happening in this next paragraph, this is occurring because of what just happened with performing the pulmonary thrombectomy. So when I look at this, I'm like, okay, you can't code it as a 37186 because that's going to be an arterial code. And you also don't use 37186 with the 37184, correct? So that's not an option. And then this is venous, we're in the IVC. And so to me, I personally considered this still a continuation of this particular procedure. I don't personally feel comfortable coding with 37187 for an additional procedure because I see this as a complication that occurred with the procedure that was being performed. So I personally don't want to code 37187 for this case for this additional work because it was caused by the pulmonary thrombectomy looking at the report. So the only thing that I'm assigning for this paragraph, if I have to make the decision, is 36010 for the cath of the IVC. So I felt like that's kind of like my compromise, like my gray area. Like I'll count the catheter work, but I won't actually pick up the additional thrombectomy in this particular case. So for this paragraph, I'm personally going to assign 36010, and I have the excess for a separate axis to denote that. And then when we come down to the next paragraph, it says the second axis was then obtained in the left common femoral vein. So it's in the LCV, but it's still the third axis, okay, total. So we've had 3 different punctures. This is the third puncture. And again, we don't have the documentation for the ultrasound guidance. And then here we see It says a left common femoral vein venogram was performed, confirming thrombus extension into the iliac vein. So again, we're assessing, okay, where's the thrombus based on what has occurred? And then we see that the next sentence says that an aspiration sheath was then advanced through the right common femoral vein access. So over here, even though we have this second access into the left common femoral vein, which is our third separate access, the catheter doesn't get advanced to the IVC, or it doesn't get advanced to the contralateral extremity. So that's a 36005 for that puncture. And again, I put an excess on that to show that it's a separate, structure, it's separate puncture. So that's not going to bundle with the other catheterization codes that we have. And then you'll see where it says that the sheath was advanced through the right common femoral vein access. So what's happening here is this particular access is going over to the contralateral vessel where the thrombus is sitting. So it's going from right to left. So to me, that appears to be a 36012, removing the thrombus from the left common iliac artery from the right. So that's a 36012. And then I put the XU modifier on that. Now, again, I have the 37187 question mark, question mark, question mark. So we have thrombus being moved from the IVC and the common iliac. But again, going back to, we have this issue because of the thrombectomy that was performed. I didn't actually want to code for the thrombectomy. So then we see some additional imaging that's going on to check to see whether or not there's any like residual thrombus. So I'm not going to read through all of that because essentially this was really the last part of the procedure where any codable work is being performed at this point in time, because it's really just checking at that point. So, and then we see the conclusion. It just says successful removal of large amount of thrombus from the right and left PA branch systems. So again, we see that this was all focused on the pulmonary arteries. So what was occurring outside of the pulmonary arteries was not an issue. It was a result of doing the pulmonary thrombectomy. So when we come down and we look at the actual final codes, what I've done is I've given you two code lists. The first code list is if you do have a complete right heart catheterization, that will be a 93451 with the 93568 and 93573 for the pulmonary imaging that occurred. All the catheter work is going to be bundled there through that particular access that was utilized to perform that procedure. We have the 37184 with the modifier 50 for the bilateral thrombectomy. And then for our catheterization codes, we had three separate access sites. Now, the original access site where I assigned the 36012, that is allowed because that's in the extremity. It's not actually in, part of that pulmonary thrombectomy. So the catheterization is coded separately. If it had been related to the heart cath or to the thrombectomy, then no, it would not have been coded, but we're in the lower extremities. We're in a different vascular bed there. So we do get the catheterization for that. And then I showed in the report where I picked up the 36010 for the IVC and then the 36005 for that third access where the catheter didn't get moved any further. And then again, I have the 37187 with the question mark. I personally don't feel comfortable coding that for this case. So again, it's going to be judgment call on that, whether or not you feel comfortable. I feel that it's adequate to capture the additional catheter work, but not charge for the additional therapeutic intervention there. And then beneath that, we have the codes without the right heart catheterization. So you'll see here, now we're going to code for the catheterization associated with the pulmonary thrombectomy, the 36014 with modifier 50, or depending upon how you interpret this report, I said possibly a 36015. I went more conservative on this. And then we have the 75743 for the bilateral selective pulmonary imaging, 37184 for bilateral pulmonary thrombectomy is the same. And then you see the catheterization codes, there also are going to be the same as well. So again, going back to the original point that I made when I started, discussing this case, you can see that first question I had about the right heart cath. that is going to drive the coding for the rest of the case. So you see the difference there on the first three codes in that top line versus what the first two codes would be in the second line, with the rest of that being coded the same. So for this, I would probably go back, dig into the details a little bit more, confirm for sure that I have a 36015, because it possibly could be that, and then also confirm on that right heart cath. So the person that sent this in, oh my goodness, I feel for you, because I had to read this report multiple times and I actually had to dissect it. And I'll tell you a little trick that can kind of help you with this. So what I did was I took the report text and I put it into ChatGPT, and I actually had ChatGPT break it down for me and summarize the steps that were performed through each access. So ChatGPT didn't code it for me. It cannot code reports like this. There's no way. But if you have a situation where you have a case that has a bunch of steps and you're kind of confused, like what's occurring through where, that's a nice little, way that you could potentially use it. Obviously, if your employer doesn't want you using ChatGPT and throwing anything in there, I'm going to throw that out. Don't do it. Okay. I know employers have policies around it. Maybe you have something internally that you're allowed to use, like some AI tool. But ChatGPT was helpful for me in that, okay, now I have this summary, bulleted summary, and then I go back and I make sure it matches up with the report. I didn't trust that ChatGPT gave me the right information, but by taking the summary of what was done through each point of access and then reading through the report, that helped me actually distinguish the steps very clearly. And then I was able to go back and actually say, okay, now I have two ways of potentially coding this case with the right heart cath and then without the right heart cath. So for what it's worth, those of you, when you are, learning how to code and playing around with reports, sometimes that can be helpful. So full disclosure, I did that with this case because I read it through several times and I was like, okay, I can't even keep straight what's going on through what. So that helped me put all the pieces together. So hopefully you learned something from this case. Again, I'm going to emphasize the importance of complete documentation. Obviously, a lot of cases I've been doing on Wildcard Wednesday, that's something I've talked about. I've talked about missing documentation or incomplete documentation. So I always say interventional radiology coding, cardiology coding doesn't have to be difficult if you have good documentation. So documentation is usually the biggest hurdle. So those of you who sent in cases, thank you for sending them in. I'm almost through all the cases that I received. So please send in some new cases for me so I can continue doing a couple every week. So thank you everyone for tuning in and have a great day.